So tonight we're going to have got sort of 4 parts to tonight's webinar. So we've got 3 students who've joined us today. We've got Luke, we've got Sam, we've got Stuart, and each of them are going to be sharing a presentation they did as part of the MSc program in emergency and resuscitation medicine. And they're going to be about 10 minutes long, each of those presentations, and then there'll be an opportunity to ask some questions afterwards. At the end of that, we're then going to have a group discussion about what it's like to be an MSc student. And I'll ask them a few questions on your behalf, and then you also have a chance to ask some questions if you've got them. We've also got Chris with us here tonight, who's our administrator for the Emergency Medicine and Resuscitation Programme. And she'll be here to answer all the technical questions. And we've got David very kindly from the Blizzard Institute, who's helping us to coordinate and to make sure everything runs nice and smoothly. So first person to speak tonight is Luke. Luke Winterbourne is an emergency department nurse in the NHS and in the Army Reserve. He's currently seconded as a resuscitation officer until November, and then his focus will be switching back to emergency nursing and writing up his MSc dissertation before he then deploys to Mali with the military next summer as part of a trauma and surgical team providing pre-hospital damage control surgery and resuscitation. So we're going to have Luke's presentation, please.
Hello. For the next 10 minutes, I'd like to talk to you about the response to a mass casualty event in my place of work. My name's Luke Winterbourne, and I'm a charge nurse in the emergency department at Salford Royal, a major trauma centre in the northwest of England. As a major trauma centre, treating trauma patients is a common part of my job. Falls are the most common trauma presentation. These usually only result in one patient attending at a time though. Road traffic collisions and assaults are also common trauma presentations and occasionally provide us with multiple casualties from a single incident, although again this is rarely an issue. Mass casualty events are something that require special arrangements to be implemented. These arrangements are outlined in our major incident policy. Major incidents can occur for lots of reasons and don't always result in an increased number of patients, but with those incidents that provide enough patients to potentially overwhelm the system that I'll be focusing on today. Rather than outlining this 57-page policy over the presentation, I'm going to take the time to outline the response to a mass casualty event which resulted in a major incident being declared. On the 22nd of May 2017, a suicide bomber detonated an improvised explosive device at the end of the Ariana Grande concert at the Manchester Arena. Including the bomber, 23 lives were lost and over 800 people were injured, making it the deadliest terrorist attack in Britain since the London 7/7 bombings. Many of those wounded were children, and the youngest fatality was just 8 years old. In order to understand the response, it's important to have some background knowledge on major trauma and incidents in the region. Trauma centres in England are shown on the map on the left, and Greater Manchester is highlighted with the blue arrow. On the right, Salford is highlighted with a red circle, and the Manchester Arena is located under the black dot pointed to by the red arrow. The region has a second major trauma centre, MRI, the Manchester Royal Infirmary, which is located to the south-east of Salford Royal. On the same site as MRI is the Manchester Children's Hospital, which is the paediatric major trauma centre for Greater Manchester. On the night of the 22nd of May, the bomb was detonated at 22:31. Much of the arena is located on National Railway property, so British Transport Police were the first on scene. They declared a major incident just 8 minutes after the bomb was detonated. The first paramedic from the North West Ambulance Service arrived within 3 minutes and was soon joined by an advanced paramedic colleague who from the scene declared a major incident just 15 minutes after the initial explosion. 3 minutes later, there were 12 ambulances on scene and news of an incident had started to spread. For hospitals, it was this declaration of the major incident from the ambulance service that started changes in the hospital and across the emergency departments in the region. Contrary to the usual handover of pre-alerts from the ambulance call centre directly to emergency department staff, the declaration of a major incident comes to the hospital switchboard. Switchboard operators then contact the major incident call-in list, initially starting with managers who would oversee the hospital and respond to the incident. Staff would be called by their own department later on as the night goes on if required. Information comes to switchboard in the form of the acronym MEFANE. This acronym is used to share information between different services who would be required to respond and is familiar to anyone involved in major incident planning or in completed training such as the MIMS course. Situations like this, frequent updates are required as information is continuously changing. For hospitals to prepare, the declaration of the major incident is what gets the ball rolling. The location follows this up and provides information as potentially how far away and how long it will be until patients arrive. The type of incident allows staff to prepare for what is often uncommon injuries and different presentations to what we are used to. The number, and later, in addition to the triage category, the number of expected patients allows the hospital to prepare adequately. Triage is an important part of major incidents, and a triage sieve, such as the one shown, is used on scene to prioritise treatments and transfer. P1 casualties are those who require life-saving resus and/or surgery and should be triaged appropriately so they can be prioritised first. In addition to treatment and transfer, triage in Greater Manchester is also used to transfer patients to the most appropriate place. Salford Royal is a major trauma centre and has neurosurgical and spinal surgical capabilities 24 hours a day. Burns and plastics and vascular surgery is not on site, and patients requiring these services would need to go to Wivenshaw Hospital. Cardiothoracic surgeons are based at the MRI, and anything for paediatric patients would be at the major trauma centre at the Children's Hospital. Choosing an appropriate hospital to transfer patients can be a difficult decision. In 2013, Fuller et al. Completed a diagnostic cohort study including 6,559 patients. The sensitivity of the London Ambulance Service and the head injury transportation straight to neurosurgical triage criteria was assessed to see how useful it is in it was assessed for sensitivity of identifying patients with a traumatic brain injury to take them to the appropriate neurosurgical centre. Sensitivity was found to be poor in these tools, with just 44.5% and 32.6% respectively. Fortunately, this does not seem to be the case in the Manchester Arena bomb, with only one patient requiring transfer from their initial hospital. Perhaps this study isn't relevant in this incident because of the different age. Patients in this study had a median age of 55.1, much older than many of those who attended the concert. Of the 160 patients attending hospital, 40 of them were children. As part of the planning for major incidents, Operation Socrates took place in March 2017, just 2 months before the arena bombing. This exercise identified that Greater Manchester had the capacity to treat up to 300 patients for a single incident. It was decided that up to 20 P1 casualties would each go to Salford Royal, Manchester Royal and Wivenshaw hospitals. P2 and some of the P3 casualties would be split across trauma units in the region, and P3 casualties remaining would attend local hospitals, walk-in centres or mass casualty treatment centres if not able to be treated and discharged from the scene. As part of the handover from the ambulance service, 12 P1 adult patients were triaged to Salford Royal. Looking here at a site plan of the emergency department at Salford, ambulances arrive via an entrance separate to the waiting room and the main reception, highlighted here with the orange arrow. There's an 8-bed resus area, highlighted by the red circles. In the event of a mass casualty incident, the ambulance triage area and the major's high dependency area, highlighted by the yellow circles, would all be able to treat the P1 casualties as well. The bottom half of this image shows the rest of the major's part of the department, which would be able to treat any other patients from the bomb or from other incidents or requiring any other treatment. Additionally, patients could be transferred to the minor injuries unit or the paediatric assessment area, which isn't located on this site plan and accessed through a different entrance. The blue dots show the location of the CT scanner and X-ray department, and any patients requiring transfer to theatre or ICU would leave by the brown arrows and use the lifts highlighted by the brown circles. On arrival, the 12 P1 casualties were met outside by a senior ED clinician and ED nurse and triage again using a triage sort. This tool was used to identify which patients would be treated where in the department. The early declaration of the major incident by the ambulance service meant all these cubicles were now empty rather than full as they were just an hour earlier. Additionally, trauma teams who had been called in from home had been formed and each patient had a trauma team allocated to them. For many major trauma patients, such as those in this bombing, blood transfusion was required. The PROMPT study in 2013 compared the use of early transfusion of plasma and/or platelets against time-varying plasma to red blood cell ratios and time-varying platelet to red blood cell ratios. Higher plasma and platelet ratios early in resus was found to be associated with decreased mortality. Decreased mortality in patients was seen in those who were given at least 3 units of blood in the first 24 hours of admission. 1,245 patients were included in this study from 10 different level 1 trauma centres in the US. It was found that major trauma patients who received at least 1 unit of blood were found to have a 21% mortality, and this rose to 25% if 3 or more units were given. Patients who received ratios of less than 1 to 2 were 3 to 4 times more likely to die than those receiving ratios of 1 to 1 or greater. Like many trauma and research studies, there is unfortunately a risk of survival bias, as patients who suffered substantial bleeding and did not survive at least 30 minutes were not included in this study. Ratios of red blood cells to other products were also found to be inconsistent across patients, but it was clear that an inadequate transfusion of plasma or platelets would lead to an increased mortality. So, at Manchester, during the bombing and at Salford Royal, the haematology major incident procedure began less than 30 minutes after the bomb being detonated. Lessons learned from trials and studies such as the PROMPT study and lessons learned from Operation Socrates made the blood bank lab coordinator make the decision to defrost plasma ahead of patients arriving and prepare additional packs of emergency O-neg blood. Between 11 p.m. and 4:30 on the night of the bomb, 27 units of red blood cells were used at Salford Royal. Across Greater Manchester, 334 units were issued, and additionally, Salford Royal administered 2 litres of fresh frozen plasma, 2 litres of octoplas, and 3 units of platelets. From reviewing these patients retrospectively, it has been acknowledged that at least 2 lives were saved from the transfusion of blood products who would have died without this treatment. All 12 patients who were admitted survived to discharge. A little over 4 hours after the bomb was detonated, the last patient was transferred from the casualty clearing station at 2:46. Later that day, Salford Royal stood down their major incident, but it's since been recognised that this occurred too soon. Up to 8 operating theatres were in use in the hours after the bomb, a huge increase from the usual 1 or 2 theatres overnight. It wasn't until 2 days after the bomb, when additional elective surgical cases were cancelled, that it was recognised that patients would require multiple trips to theatre over the following days and weeks.
Thank you, Luke. So does anybody have any questions for Luke about that, about the response that they had or how they managed it? My question for you, Luke, really is, what was the big learning? Now, obviously, this is a real life major incident that you're involved in. It's we know that there's some papers and things coming out of it now from the team up in Manchester and things. But for you as an emergency department nurse, what was the one big learning you took away at the time? And then having done this presentation and read the research, was there anything that changed your thoughts or might change your management in retrospect?
I think the biggest thing was probably the blood products. So we used more blood that night than we've ever used in a day. I think more than 2 or 3 times more than what we've ever used before. I probably didn't know the evidence base behind it. We just knew that blood was good in trauma and that if they lost blood, we'd replace it. But definitely in the last sort of 2 years, having read more about the research around it, it's probably shown that we've actually done it the right way, which was quite nice to know.
And obviously that was really proactive of the transfusion team to think, right, this is what it looks like it's coming in. We're going to just start defrosting now as soon as we can. Did you have enough blood warmers and things like that? Was there those sort of limited supplies? Were you pulling things down in order to sort of aid that sort of this massive transfusion that was going on across the whole department?
Yeah, so although we have 8 resus bays in the department, we only have 2 rapid transfusers, and there's another 4 in the hospital that were all brought down to the emergency department, and they were all there. Because there was staff there quite early, we had theatre staff in the department a good 15-20 minutes before any patient started arriving. So we had to bring transfusers down from theatres and then follow patients up, but not that many needed surgery immediately. And the ones that did it was all damage control surgery, so quite short-lived before going to ICU.
Great. And I think it's really important, the point you made about actually the long-term effects. You know, a lot of us here are on this webinar tonight and on this MSCs because we're interested in emergency medicine, so we deal with the big trauma at the time, but actually that lag effect that affects everything else within the hospital services, there must have been effects on the ambulance services from the amount that were deployed and then can be ready to be used again, staff who are pulled in and everything else like that. You've talked about the impact on the hospital, that they stood down the major incident too soon. Did you have other lag effects in the ED as well?
Almost the reverse. So the next day in ED, we hardly had any patients come in. We had a couple that had delayed presentations with minor injuries, but less than we'd see on a normal day in minor injuries. So a lot of people, I think, probably avoided the emergency department a bit like they probably did in the first wave of COVID. So the emergency department as a whole was quieter for a couple of days afterwards. And I think the only people that we saw were people dropping off presents and gifts, and it was like Christmas Day every day.
Yeah, the support from the public was fantastic, wasn't it? We've heard that, which is amazing. Thank you. Well, I think that's really true. And I think we all feel that effect often in ED. The best day to work is the day after something significant because everybody else stays away. You get that sort of little bit of breathing space, but it's always important to think about mutual aid across the rest of the hospital. Who else is struggling? Who comes down to help us when we're really struggling? And actually, how can we go and help them when they're still dealing with those sort of ongoing effects? So that's great. Thank you so much. Well, I haven't seen any questions haven't come through from the audience, so that's fine. So thank you very much, Luke, for sharing that. That was really interesting. We're going to move on to Sam. Sam Rea is a critical care paramedic, team leader working for the South East Coast Ambulance Service. She's had many roles within the ambulance service, including working as a paramedic both on motorcycles and for the London HEMS as well previously. She's dual registered, and prior to joining the ambulance service, she worked as an ODP for a busy NHS trust, and so can bring that experience to us as well. She's joining us today from Winchester. She's in the process of moving house, but thank you for being here, and we'll play your presentation, hopefully.
Welcome to my presentation, in which I aim to give a summary of South East Coast Ambulance Service, CCAM's response to a non-contaminated major incident. My name is Sam Rea. I'm currently working as a critical care paramedic CCP team leader in the South East of England. Prior to this, I've had many hats, including working as an ODP within hospital and as a paramedic on London HEMS. Over the next 10 minutes, we're going to discuss the four main areas of this presentation in relation to CCAM's major incident response: the system of dispatch, ambulance resources available, pre-hospital triage and other resources, focusing on interventions provided by advanced practitioners, before finishing up with a few key points. Throughout the presentation, most of the information discussed around the response has been taken from my Trust Major Incident Plan, National Guidance from NHS England and NARU, who are the National Ambulance Resilience Unit. All NHS-funded organisations have a statutory obligation by law under the Civil Contingency Act to provide a specific response to a major incident. So looking at dispatch, in a major incident, our initial call may be from another agency, such as police, fire or another ambulance service, advising us of the event and giving details. This then triggers a predetermined course of action that allows us to respond immediately to the major incident with a full scale of resources. Often, though, the initial calls are from the public via the 999 system. These are assigned a category from 1, immediate threat to life, to 4. And this determines the speed and type of response the patient gets. As these calls are taken by non-clinical staff, there's also a risk that significant injuries and illnesses get missed, and the patient's assigned a low category of response. For this reason, both HEMS and CCPs have staff in our control room who listen and filter through all the calls received to attempt to identify these critical patients. Although HEMS and CCPs have immediate dispatch criteria, much of the dispatch is done on clinical gestalt. We're looking for the one job in hundreds of calls that needs advanced interventions based on our clinical knowledge and experience. This overview often means we're the first to link calls together. The main indicator to many of these major incidents is not the category of the call, but seems to be the volume of similar calls to the same location, often stating multiple patients are involved. Once we suspect a large incident, we dispatch our closest resources and ask the first crew on scene for a methane report. It's worth noting that the major incident declared box is separate, as often the scale of the incident is not clear, or probably more commonly, the crew are reluctant to declare a major incident in case they get it wrong. This split allows an ethane report, giving all the rest of the essential information that may otherwise not be gained until someone later declares the incident. Once declared, methane initiates a cascade of events to ensure that correct command and control is in place. We also have a statutory obligation to alert other agencies using the methane to disseminate the information in a standardised way. As well as the initiation of a whole major incident command within our control room, we also have a predetermined attendance for major incidents, which specifies the minimum number of resources that need to be dispatched to scene. As part of this, the closest 10 ambulances are dispatched, and at the same time, our specialist paramedics will be sent early to scene as well. As CCPs, we can deliver advanced interventions such as sedation, thoracostomies and surgical airways, although the major thing we bring is senior clinical oversight, experience and decision making. We also have specialist paramedics in urgent care, and they can be really well utilised in dealing with the patients who have minor injuries and can safely discharge many of these from scene. We have 2 hazardous area response teams known as Heart in the Trust that are dispatched. They have specialist training and equipment to respond to a variety of incidents. They're located in Sussex and Kent, so often have quite long run times to scene, and for this reason we try and dispatch them early. They will also bring key command and support vehicles to scene, and these have all the equipment to set up the infrastructure, drugs and treatment for mass casualties, such as casualty clearing stations. We also send command staff. 5 operational commanders are dispatched. These are from our team leader workforce. On arrival, they should become sector commanders and allocate functional bronze command roles to staff. The operational incident commander and the tactical advisor has responsibilities for the activities undertaken at the scene and will be co-located alongside the operational commanders of the other responding agencies. They will provide leadership and management to the functional roles. When looking at policies, especially ones like ours with predetermined resources, I think it's important to acknowledge our weaknesses in our system. As a service, we cover a large geographical area, some of which is really hard to access by road. We also only have 1 major trauma centre within our region, meaning that if a patient has to go by land to an MTC, this can take a significant time. For example, a journey from Folkestone to King's College Hospital, which is the nearest major trauma centre to there, takes around 107 minutes. Unlike London, where vehicles can drop a patient off and then return to scene quickly, this becomes much more challenging for some parts of our region. It also means that finding 10 ambulances for the initial resource is a real logistical challenge. This is demonstrated again here. These are real timings from a major incident that happened in Kent, and they speak for themselves, especially the time taken to declare a major incident, move the first patient from scene, but crucially the arrival of the tactical commander, who takes 3 hours and 15 minutes to arrive. So moving on to triage. Once on scene, crews will be allocated the role of triaging in pairs. We use the NASMED triage sieve, and a copy of it should be in every trust vehicle. This uses answers to simple questions to assign a category to the patient, indicating the potential severity of their injuries, and a smart tag is attached to the patient indicating this. A triage sieve is designed to be rapid, reliable and reproducible, but it also needs to be accurate. Our NASMED sieve under triages head and chest injuries does not take likely clinical course into account, for example, those with airway burns. It's also reported to lack accuracy that's required to adequately identify those needing life-saving interventions. The expectant category is intended for patients who have a poor chance of survival and who use significant resources. There is, however, no record of this ever being invoked in the UK. Modified triage, sometimes called red or dead, can be used in the place of a standard triage sieve. It's designed for a ballistic environment and labels all alive casualties as P1. It can be instigated due to the need to assess high numbers of casualties quickly in a potentially dangerous environment. It's also useful as the NABMES triage sieve can under-triage penetrating injuries. It also potentially causes problems as everyone's a P1. We don't then have a clinical order to evacuate patients, and it also necessitates a need for re-triage immediately on arrival at the casualty clearing station. With limited resources, having all the patients marked to receive immediate care may well overwhelm the system, especially as there's no way of knowing which P1 patients are the most critical. Paediatric triage is always emotive and challenging. If there are small numbers of children involved, we would probably use the adult triage sieve and accept a degree of over-triage. However, if there are large numbers of paediatric patients, this over-triage means reducing resources available for true P1 patients. Within the UK, NHS England advocate the use of smart paediatric triage tape for pre-hospital and jumpstart for ED use. A trial compared both of these systems and found neither had good sensitivity to identify those that were seriously injured, which they defined by the ability to identify patients with an ISS of more than 15. However, they both had good specificity to those not severely injured. The take-home message, though, is neither tool is validated, and most trials use retrospective trauma registry data and not data from major incidents, where the extent of injuries is not always known. Patients are moved from scene to a casualty clearing station. Here, the triage sieve is followed in CCAM by a secondary triage process using the triage sort tool. However, a retrospective review found the primary NASMED triage sieve we use is both quicker and more sensitive than our secondary sort, suggests we need to develop a better secondary triage tool. So finally, let's talk more about some of the other resources and advanced interventions that may be used by these teams on scene. CCAB have a contract with Kent Surrey Sussex Air Ambulance that in the event of a major incident, they will provide the Mobile Emergency Response Incident Team, or MERIT function. This role is set out in the NARU guidelines and is a requirement to assist with triage, treatment and appropriate specialist interventions as required. Many of our CCP workforce are current or emeritus HEMS paramedics and therefore could feed into this MERIT function on scene. Although the helicopter could be used for patient transport, it may be of better value carrying additional HEMS teams and equipment to the scene. Mutual aid from other HEMS can then be requested, and these further air resources may then be better placed to transport patients long distances to major trauma centres. The levels of intervention undertaken is a really interesting discussion point that I'll try and touch on. The initial actions of merit are clearly defined. The first doctor should assume the role of medical advisor, and the next team should become the casualty clearing station medical lead. Past these roles, though, I would suggest there's no clear answer as to how enhanced care teams are best used on scene. In terms of interventions, it will be totally situation dependent, more realistically be driven by the number of Cat 1 patients. If there are not many critical patients, it may be more appropriate to offer increased levels of interventions, accepting this ties the clinicians up. This is less realistic, though, with high numbers of critically injured patients, such as with ballistic injuries. It becomes a real moral dilemma. It may be appropriate to do a time-critical intervention, be this Reboa, blood, RSI for an airway compromise, or thoracostomy for a patient with a tamponade. The question, I think, revolves around the number of patients that we have that are critical and the futility of the procedure. Can we justify tying the team up with one critical intervention when we could be better used for 10 or 20 other patients? I suspect this is part of the reason that we have senior clinicians in this role to help make those difficult decisions. Over the last 10 minutes, we've looked at how CCAM and other agencies would dispatch, resource, triage and treat patients in a non-contaminated major incident. In summary, these are challenging, dynamic and difficult scenes, and we can't have a one-size-fits-all approach. We can improve our skills in the area, though, if we follow guidance, know our roles, realise as much as possible with other agencies, and research areas where evidence of benefit is currently not clear. Thank you for listening.
Thank you so much, Sam. That was really fascinating, especially somebody like myself who's got very little pre-hospital experience. Just for those who might not be aware, what does MERIT stand for? You talk about the MERIT team.
Yeah, so the Mobile Emergency Response Teams, essentially they're a function that is a requirement by law and tends to be done by HEMS services. It involves getting a doctor and a team, it doesn't specify the other person, but generally a paramedic, to scene to give clinical oversight and offer those advanced interventions. And for our colleagues who are abroad, just explain what HEMS is as well, in case they haven't come across it. Yeah, my apologies. So in the UK, HEMS traditionally is using helicopters with a physician paramedic team working on them that tend to go to our critically ill patients. They're not linked to the ambulance services, they're all generally charities, but they do respond for ambulance services. So yeah, they work alongside the ambulance service to respond to those critical patients. And these are generally our only pre-hospital doctors, aren't they? Because the rest of the pre-hospital, we don't have pre-hospital doctors on any of our land-based ambulance services unless it's an overnight HEMS team that's working from a car. Yeah, absolutely. So our main bulk of our workforce are ambulance service paramedic based, and their level of paramedics varies across the country as to who you get. I'm very lucky to work in an area where we have critical care paramedics. But lots of places the land paramedics work really, really hard with these sick patients. And what's the difference to become a critical care paramedic versus a standard paramedic? So you go away and do a postgrad certificate in critical care alongside quite significant hospital placements. So we spent about 4 months in hospitals rotating through theatres, ICU and A&E, just to make sure we can take some of the skills from in hospital earlier on in the patient's journey, really. Excellent. I was really interested. You talked about how, do post any chat. If anybody's got questions from the audience, please do put them in the chat. I'll keep an eye out for those. Otherwise, I'll ask a couple. You talked about how clinical gestalt was so important. You know, the role of actually piecing together these different calls coming in and things like that. And this was an area that we got some students in the first year, MSc students actually wrote an assignment about clinical gestalt versus clinical decision tools, which was really fascinating, and how often clinical gestalt is better or as accurate as the decision tools. And that led me on to the next thought. You were talking about there's all these different triage tools that exist, but none of them seem perfect or particularly good. There seem to be a lot of weaknesses in them. I think they're trying to make, the problem is that the patients can present with anything, any sort of injuries from any environment, be it ballistics, be it, they tend to come in clusters when it's been big events, whether it's, an attack, there's been some sort of biological attack or there's been a ballistic attack. And I think that none of the tools are sensitive enough to be able to properly put the patients in the right category. And we don't do it very often. We don't get these tools out. We don't practice with them enough. We try on scene if we've got not that many patients, but more than one or two, to make sure we get our major incident cards out and we try and use them, because familiarity is everything, I think, with these. But yeah, it seems difficult to find one that fits all the situations we need it to.
So given the fact we seem to have more defined incidents these days, there might be a ballistics one, there might be a fire one, something else like that, and the fact that we rely on cognitive decision aids, so we take out the list from the ambulance and we use that to help us make the decision rather than relying on our memory. Do you think there's a place for actually multiple tools, and you assess the scene, what type of scene it is, and then you choose which one's most appropriate?
I think so, although I think we run the risk that we don't use one of them enough. To then bring in more might be more confusing for staff. So I think the thing about major incidents for the ambulance service is you're often asking quite junior members of staff to declare a major incident. That's quite a big thing to do. And so I think that using these tools, people are quite scared of them. They don't want to be the person to say they've got it was a major incident and they were wrong. So I think we need to keep it really simple, but it needs to be effective. And I think that's what people have been trying to do, but we haven't quite got the balance right.
We all don't mind standing down from a major incident. It's a bit like, oh, phew, can breathe again. And that was my last question, really. You said you have to dispatch HEART really early because it can take a long time for them to respond. A, just tell everybody what HEART actually stands for, so they're aware of that. But B, how often do they go and then return rapidly and actually do stand down versus?
Very often. So HEART's our hazardous area response team. So they essentially take on some of the roles of the fire brigade. They've got some urban search and rescue skills. They are all paramedics, but they work quite differently to the ambulance service. So they are, again, that we have to have a HEART team within our trust. It's funded differently, and they respond to kind of water incidents or big road traffic collisions, all of those things. But yeah, they're a long way away. There's only 2 teams on for our 3.5 counties that we cover. So quite a big chunk of the kind of southeast coast of England. So we send them really early and stand them down a lot of the time. Or they'll go to scene to help with things like extrications, but not that primary role if looking at kind of major incidents.
Great, thank you so much. It's really good to have you here and to share your insights there. So finally, we're going to move on to Stuart. Stuart is an emergency medicine registrar in Edinburgh and has just finished his ST4 year of training. He's really interested in human factors in resuscitation settings and how do these play into the relationships between pre-hospital and in-hospital teams. So I'm waiting to see if I'm going to have a dissertation student doing some human factors in the coming year who's going to be assigned to me, which would be exciting. We're going to listen to Stuart's presentation and then we'll ask him a couple of questions too.
Hi, I'm Stuart Hamilton and I want to spend the next 10 minutes talking to you about the management of mass casualty events here in the city of Edinburgh. So I'm going to spend the first part of this talking through the background of mass casualty incidents and planning for those, geography and why this is relevant to our setting, the activation process by which we would stand up for a major incident, how we would manage these within the ED, the stand down process and a little around staff wellbeing. So I am a hospital-based emergency department doctor. We have a pre-hospital team located from here who will deploy with an A&E consultant and registrar, forming one of our pre-hospital services. We are the adult major trauma centre for the south east of Scotland and the children's major trauma centre for the entirety of Scotland's east coast. And the picture at the bottom there depicts the children's setting on the left hand side and the adult setting on the right hand side, with the resus windows being depicted just behind the 2 ambulances parked in the middle there. We have a helipad on the roof of the children's side just to the left, so very accessible for all of our services. We are on this map represented by the red plus in the bottom right hand corner there. So fairly central in Scotland, representing around 30% of the UK's landmass, but only with 10% of the population. We have, across Scotland, half the population of London, but just as many major trauma centres, and that's because of the unique geography of the country, in that we have approximately 20% of the population living in very remote and rural communities. Across this map, the shapes as squares, triangles and circles represent smaller hospitals, which would also take part in our trauma responses. Some of these are very, very isolated and possibly may only have 1 or 2 clinicians on site at a time, with 1 or 2 responding ambulances on each of the islands. That leads into us having a national major trauma network system, which means that these patients are able to be fed into the central MTCs. So we, as I say, provide the Children's Major Trauma Service for the entirety of the East Coast, and why that becomes relevant is up in the islands of Shetland and also in the northeast of the country in a place called Stonehaven. They like to have large festivals with fire. So that picture in the top right corner there is Up Helia, which is a Viking fire burning festival, and it's not difficult to imagine how things could quite quickly go wrong there, and that for us could well turn into a mass casualty event, but it's likely we would have a long period of warning before these children were arriving in our services. And that was much the same in the 1980s disaster of Piper Alpha, which was an oil rig that exploded in the North Sea. The city of Edinburgh and Glasgow were stood by to receive casualties, but were thankfully never required. Far closer to home, major international events such as the Edinburgh Festival and the Edinburgh International Street Party bring somewhere between 1 and 2 million visitors, transient visitors, to the city of Edinburgh over the months of July and August, and then again in December, and that's probably our highest risk flashpoint for terror incidents or for roving mass casualties. Across in the West Coast, football plays a major part in things that lead to disturbances, and the old firm clash between the clubs of Rangers and Celtic often leads to mass gatherings in pubs, streets, and it's not unusual for that to descend into quite significant violence, which can lead to a large number of people ending up in A&E departments and putting significant strain on services right across the country, despite it being quite a disseminated event. So how would our process be activated then? So we would typically receive a methane report from our pre-hospital colleagues, and that would, in a perfect world, come from the Major Trauma Services desk located in Glasgow. A decision would then be made. Staff are put on standby, and what that really means is how many staff do we have available and how quickly would they be able to get to the hospital, or saying this isn't going to represent a major incident for the hospital. And the classic examples of that would be something where there are a large number of people trapped, or people in a very remote location that's going to present quite a significant challenge for our pre-hospital colleagues. One other crucial part, I suppose, in all of this process is that our Police Scotland colleagues can also, in exceptional circumstances, make this activation, and that's there really in case of hostile scenes such as we've seen in Paris, where the police have an understanding of a large number of casualties not yet seen by medical services. When a major incident is declared, our department is locked down with single points of access and egress for major incident and non-major incident patients, and that's following a simulation exercise a few years ago where check-in and check-out of patients was quite chaotic. People weren't entirely sure where patients were, whether they'd left the department or not, and that's why we use that system. Another problem that we've identified by trialling this is that mass casualties are identified by a unique number rather than their own name, and we did that following a bus crash where patients who were all called John arrived in the department. Nobody was quite sure of their surname, and we had 27 people under the name of John in our department at one time, and you can imagine how quickly things could go wrong from that perspective. So just to put that into a slightly more graphical format, the 3 people that can activate us really are the Scottish Ambulance Service, our red teams, which represent our Special Operations Response paramedics, our critical care paramedics, and our pre-hospital emergency physician and anaesthetic colleagues. And lastly, probably not in a mass casualty, but more of a volume presenting to the department, the emergency physician in charge or the service manager can also activate this plan. That preparation phase, as I say, then leads into the immediate clearance of the ED to create space, and that involves a large number of our colleagues coming in from medical specialties and people that wouldn't typically be thought of as being involved in a mass casualty event. So clearing, for example, medicine of the elderly wards, clearing acute medical assessment space, and ensuring that they are adequately staffed was certainly something that's come in the later revisions of our major incident plan. We suspend our emergency operating theatre and our 4 trauma theatres, with cases only being allowed to continue in our other 21 theatres on the express wish of a consultant surgeon. This is life or limb threatening surgery until the incident is better understood in the hospital context. We also have this unique feature that across Scotland a team of volunteer blood bikers are activated, and that's possibly less relevant to us because the blood bank is located in Edinburgh, but for our colleagues up in Aberdeen and Glasgow, it means that if blood products need to be moved from the National Blood Bank to the hospital, that process is well underway by the time casualties start to arrive. Staff call-in is an interesting perk of our system in that the first 2 trials of this, WhatsApp groups became the front runner of a way to get staff to attend the hospital. We discovered that switchboard were very quickly overwhelmed as they tried to call in emergency department staff, intensive care staff, theatre staff, and everyone else required in that setting. So departments now try to individually activate as many of their own staff as possible and get them moving towards the hospital prior to the switchboard needing to be involved. We also, just touching a little on that staff wellbeing issue, we move immediately to a departmental disaster rota, and really the purpose of that is ensuring that we do not have large numbers of staff on annual leave or study leave, and of course that's much easier at the moment as people are less able to travel than they would be in normal times. So this has quite a significant knock-on impact for our staff. Following that, we then move into the arrival and triage phase of our process. So within the ED, we separate the department out, and we really separate that out based in a mass casualty setting between major incident casualties and normal casualties. Within those areas, we then subdivide that again into ambulance arrival versus self-presenters. We're very unlikely to see a large number of self-presenters. We're located approximately 3.5 miles from the city centre, so most of our casualties are expected to arrive either late down the line or by ambulance, and that's quite different to what's been seen in London with the London bombings, or by our colleagues in Paris, where casualties were self-presenting at times prior to a major incident being declared, and hospital staff often had much more of an awareness before the plan had a chance to be activated. So I think we're quite fortunate in that regard. Staff are asked to attend or stand by, based again on whether that incident has been declared or stood by, and all staff are assigned to an action point. I'll come back to that in just a couple of moments. One senior member of our staff, which should ideally be someone with clinical experience, a consultant or a charge nurse, is allocated into the hospital control room, where a team specifically from the blood bank, one of our hospital bed managers, and a media liaison officer are located so that Gold Command can disseminate that information quickly throughout the system. When patients arrive in the emergency department, there has been work from the TARN database that was completed in 2014 that recognises in difficult and hostile scenes patients are often, injuries can be missed in these difficult settings, and therefore patients must be re-triaged when they first arrive in the ED. We take our P1s to resus space with designated teams for each base, our P2s into designated major area, again with designated teams, and we return P3s to the emergency department waiting room, and then they optimally move into our standard ED triage process, although if numbers do become exceptional in that part of the department, the clinician in charge can employ the triage sort system. Our staff should all be aware of a predetermined major incident plan and are able to use the single sides of A5 to remind them of the actions that they should be taking in their designated role. Checklists are mandated for all high-risk interventional procedures within the department, and that's become part of our day-to-day practice for major incident planning. We employ a one-way system throughout the hospital and all departments. This continues through the theatre corridor, intensive care and designated step-down wards, and that really means that patients can be electronically and physically checked in and out of each area to ensure that people are not lost during that process. Walking patients, or those being discharged, either exit via a non-major incident or a major incident door with a designated member of ambulance administration staff at each door. Our stand-down process is made by the Gold Command team, and we have a system where different parts of the hospital will be stood down at different times, and that follows that patients will arrive first in the ED, but likely the intensive care pressures are likely to be present for some time. For as far as possible, we try to debrief in the emergency department using a standardised tool, which is a Stop 5 system that was published in the Emergency Medicine Journal with a link available on my final slide. So, to conclude, as yet our plan has only been tested in simulation settings for mass casualties. We are unlikely to see a large volume of self-presenters, and we incorporate staff wellbeing into our planning. I present to you my references and would be happy to take any questions there. Thank you.
Thank you so much, Stuart. And again, if you have questions for Stuart, then do pop them in the chat there, and we'd be really happy to take them. I'm interested by this concept of your blood bikes, because as you say, you're covering a huge geographical area, which would take, I mean, it takes an hour and 117 minutes to get from Margate to London, but to get from the Shetlands or to get from north coast of Scotland down to Edinburgh takes significantly longer than that. So who funds the blood bikes and how do they work?
So our blood bikers are
fairly committed bikers who volunteer on an on-call basis that are quite an amazing bunch of people actually who step up to move blood samples around the country and effectively function on an on-call basis. We've stepped up massively over the last few months during COVID to help us moving samples and moving other bits and pieces around the country and do all of this in their own free time.
Did they get a special license to go faster on the really good biking roads in Scotland?
So they all go through Police Scotland's blue light training process and get properly liveried bikes and things. So,
and how many of them end up as patients? Because as emergency physicians, we know that this is a core part of our work sometimes.
Touch wood, none so far. Never say never, I guess.
Never say never. No, exactly. You make a really interesting point, which I think anybody on this call, I know a couple of people on the call have been involved in major incidences, that actually we talk about cascading information in the hospital through switchboards and things like that, but actually WhatsApp, BBC News, other ways are usually the way this information comes through and things. Has there been a rethink about how information should be shared as the official channels?
Yes, our primary call-in channel now for certain doctors in the emergency department is via WhatsApp groups, which actually take probably more work to administrate than any of the other systems that we have, trying to keep people's mobile numbers, WhatsApp groups and stuff up to date. So having someone dedicated doing that and keeping an eye on that is very, very useful.
So you have a major incident WhatsApp group?
Yeah. So we have a WhatsApp group for the registrars and a WhatsApp group for the consultant team that are only used in the event of major incidents, which avoids all the usual sort of day-to-day chatter.
I think it should be used for education as well. You know, you could be posting some good educational content out to them there nice and regularly, but I would say that. There's a question for you from, she says, what else did the hospital ambulance service change after undertaking the major incident exercise that proved beneficial?
So is that, are you intending that question for me or for Luke?
Oh, for Luke, sorry, yes, apologies, that was for Luke. Yes, you're right. We'll come back to that. Luke, if you tee yourself up to come through. Was there anything, having done the assignment, that you looked into this in the evidence base that made you think, actually, this is a practice we need to go back and change? I need to speak to my consultants about what we're doing, or to the local system, or to the trust?
Yes, I think our triage process has very much been based around triage sort and triage sieve, and there's not been a huge amount of thought process around, actually, as Sam's pointed out already this evening, there's definitely groups of patients that system probably fails at certain times. So there's some work ongoing to have a look into whether or not we need to be employing different systems at different places along the way.
And is work going into that now?
It is at the moment, yeah, so it's ongoing.
Excellent, thank you very much. Luke, if you're there, would you like to answer the question for her?
Yeah, of course. So what else did the hospital or ambulance service change after undertaking a major incident exercise that proved beneficial? So the big thing that the Operation Socrates did was it was a regional exercise. So it looked at how we'd work across all the hospitals. Compared to the other two presentations, we're probably the densest area. It's only a few miles between two major trauma centres in the region. So the big thing was where we'd take the patients. So the P1s went to the two major trauma centres, P2s to other places. So a lot of it was about triaging people to a specific location. The changes that they made to the blood bank and defrosting plasma and things like that was all just decided locally. The main thing was, where would we take people?
Excellent, thank you. If we could have Sam back up on the screen as well now, that would be fantastic, please, David, and Luke as well. Thank you so much, all three of you. Could one of you just, Sam, maybe you were talking about it, just say how this was a presentation, was a different, as part of the assignment for the MSc, and so this was sort of a different approach as part of the last module you took.
Yes, certainly. I found it really fun actually to do. I think we've been writing quite a lot of the assignments that they've all been written up until this stage, and I think to be able to, we had to do the same research and we still had to kind of write an essay in order to be able to present it, but it made it more, I felt a bit more interactive in terms of being able to put pictures and slides and think about how we were going to present the information, and it made me really refine it, because 10 minutes is not long to talk about such a big topic. So it made me really hone down and work out exactly what I thought were the really salient points that I wanted to get across.
And this is the first year we've done the presentations as part of the assessment. We'd now do it for module 4 and for module 8A. And all the students were given a presentation about presentations and how to improve their presentation skills. Stuart or Luke, do you maybe want to comment on that?
Yes, I think that presentation that I think Libby has the link to pop into the chat is really incredibly useful and actually makes you think a lot about how you deliver content. And I'm sure everyone that's here this evening has probably suffered death by PowerPoint at some time during their training, and to keep your audience engaged and keep chatting away. So super helpful.
I think one of the key things from the MSc is to try and produce researchers and educators and the future of emergency medicine. And so we want to make sure we've got all the skills there. It's not just able to produce a good essay, but actually to be able to talk, to be able to share your information, because going to conferences is such a key part. And the standard of dissertations we've had over the last 2 years, we've got some really good publishable work that we hope will be presented more widely. And these will help build the skills for that. Just to ask you guys a couple of questions about, you've all three of you just finished your second year of the MSc. So it's a part-time MSc. You do 2 years of taught modules, 4 modules in each year, and then you're about to go into your third year, which is the dissertation section. What's been the most challenging and what's been the most inspiring part of being part of the MSc?
I can certainly, the challenging part is the fact the modules run back to back. So you really have to be on top of everything, because you do 8 weeks and then you do your next 8 weeks and your next 8 weeks and your next 8 weeks. So for me, it was just the challenge of we've all got really crazy work schedules, and around that and life in general was just making sure that I was on my every 8 weeks in terms of making sure I had all the work done.
Thank you.
Yeah, I think definitely echoing what Sam was saying there, making sure that you plan alongside your rota for when you've got quieter parts or nicer parts of the rota is definitely a skill you have to pick up quite quickly. I think though on the positive side, the faculty on this MSc has been absolutely fantastic, and kind of people that have written guidelines, that have written really high quality papers, and having the chance on a week-to-week basis to ask them direct questions or to kind of hear their thinking about where things are heading has been really inspiring actually.
The tutorials have also been really good, because it's been a chance to get real-time feedback about questions that we have in terms of asking, running through a case, and we all talk about what we would do with it. And then it's just learning from peers and learning from the presenters has been really, really good.
So yeah, so the MSc is interprofessional, and you're representing the 3 professions here, which is great tonight. Luke, a question for you. Nursing's the least represented group on the MSc. So what would you say to other nurses to try and encourage them to come and take up this opportunity? If you would encourage them.
Yeah, I definitely would. I think anyone who works in any kind of resource, emergency medicine, emergency care knows that it's definitely a team sport, and working alongside the people that either bring you patients, you take your patients to, or you look after patients with, doing the masters alongside those people. You see that different training that they've had that got to that place, and you see how they come to those decisions and those pathways they follow. So making it all click together works really, really well. I definitely recommend it if any nurses want to do it.
Excellent, thank you very much. And obviously it is a massive impact. It takes a lot of time. It is back-to-back modules over the 2 years. Do you feel that the MSc will impact your future prospects? Do you think you can see how this is going to benefit your career pathways going forwards for any of you?
Yes, I think it massively has helped in terms of organisational skills and being able to chat through that. I've been doing that alongside clinical work. I think demonstrates to anyone going into interviews and things, demonstrates that you have the ability to do something external to the workplace, still career focused, and that you're managing that. I think it's super useful.
I think there's quite a few advantages. I think the in terms of being able to say you've got a master's is a key thing. I think especially for paramedics, where we're still quite a young profession in terms of education. I feel like our education is behind the quality of care that we deliver. But it's that, and it's also the fact that enables me to then take my profession forwards by doing things like research and understanding how to put all of these amazing things we do down into some sort of meaningful kind of practice for other people. And so I think for us as well, it's about getting some research done and that sort of kind of building on that as well.
We've got a few international students who've joined us tonight, which is great. I don't know if either of you three got any, you spent much time with the international students on the course, or how it sort of helps and dovetails in with the work that happens in the UK as well. Stuart, you're nodding, or?
Yeah, I think certainly thinking of a couple of people in particular, they've brought some really different perspectives to kind of UK practice, and certainly given some avenues of things to go away and think about for sure.
Certainly as faculty, it really challenges us because practices vary across the world and resources vary, and we can, I mean, I think tonight's 3 presentations have shown how the resources vary across geographically within the UK, and then you think about how much variation there is actually across the whole of the world, and that makes us really think about how lucky we may be in our practice, how we can improve our practice, but also how we can help others too, and learn from them and how to manage in their situations as well. So I think it's a really rich part of the course for us as faculty, having people from all over the world joining us too, and we have international doctors, nurses and paramedics who've joined, which has been really great, and they certainly get stuck into the tutorials, which is exactly what we need, so that's great. So final question, maybe, what's been the most surprising thing about the MSc?
I think for me, the most surprising things probably came quite recently, when we got the feedback from this one and we realised that 2 years was over. I remember the first module like it was 2 months ago, not 2 years ago. So it's gone really quickly. I think that's probably the most surprising thing for me.
That's how busy we've kept you. Anyone else?
I think the big thing for me has been the amount of clinical knowledge that I think we all had going into this, but didn't have an appreciation of why we do certain things. And I certainly think it's made me question a lot more of why do we do this and what's the evidence for it.
And there's a real drive towards that, isn't there? You know, it's sort of not just taking assumptions, you know, spending time exploring 4 or 5 papers about why we would use crystalloid versus other things, and actually really getting down to the nitty-gritty of that, for an example, or really understanding blood products, which has been a big thing recently, hasn't it? And has sort of featured in these presentations as well. But actually, what's the difference? What are the different trials? Keeping up to date, and the faculty make an effort, you know, once the CRASH 3 results come out, well, then let's talk about that this week, because actually that's completely relevant and up to date on practice, rather than, oh no, the plan was always to talk about CRASH 1 or something else previously and not being most up to date. So there is a real drive and an expectation as well in the assignments that people bring the latest research, and therefore use free and open access medical education from things they may find from Twitter, from blogs, from Scott Weingart or whoever else it might be, and actually use that to help sort of inform their thinking, as well as using the sort of the published evidence base. But a lot of us know now that evidence-based medicine can often be 18 months old by the time it's actually got through the sort of whole journal processes. It's getting better with online advanced publications, but so yeah, trying to be as up to date as possible with that. We've got Chris on the line as well, who is our administrator from the emergency medicine program. So I don't know if there's anything that people from the audience would like to ask for her or to ask our students before we sign off this evening and let people get back to their Thursday evening. Just to say, we are accepting applications through till the end of August, and that's for 2 different MSc programs. So 3 students here have all been on the emergency and resuscitation medicine program, but from September we are starting a new program, which is the tactical military, austere and operational medicine, which Dave has kindly just put the links into the chat for us. So this is going to be exactly the same first year, but the second year is going to have a much stronger angle on these areas, obviously. And the idea is it's pulling people who might work in different environments or just have an interest and want to go and work abroad, want to go and work in more tricky situations, might want to get more involved in terrorist, exploring what happens in terrorist incidents in the UK or wherever it may be. So do look at that and do sign up if you'd like to come and get access to all this wonderful lecturers and to this community of students and learn from the people in the different professions that you work through on a day-to-day basis. That's great. You've got a firm accepted place, so congratulations and welcome. Chris will be able to answer that, but the enrolment, so now you've got an accepted place, there's then the enrolment that come into the Students' Union, which will be on the 23rd of August, so you'll be able to get into the library from there. So I'm glad to hear you're itching to get going with that reading list for Module 1, and that's really good news, and we'll look forward to welcoming you in September. So if there's no other questions from the group, I just want to say a huge thank you to our 3 speakers. Thank you to Luke, thank you to Sam, thank you to Stuart, thank you for taking time out to join us this evening. We are going to be posting the recording of tonight's session. So if you've got friends who you know have missed out and should have watched what you've seen here, then you'll be able to share that with them, and we'll be sharing that on social media as well. And if you've got any questions about the programmes, then do contact us at the emergencymed@qmul.ac.uk result. Email address. Question for the team then. So what professional background are you from, Angela? That might see who we should post the question to. Paramedic. So question for you, Sam, what would you recommend that Angela could do now in preparation for the course?
I enjoy the summer, because it's quite a long period of time that you're then studying for. So my honest, all the preparation you need will come as part of the MSc. And I think that have a look at the shifts. It's really hard to work out shifts around the tutorials, but if you can, when you find out when the tutorials are, just see whether or not you're available for any of those, because they're really worth doing. But yeah, the stuff you need as you go along. The first module for paramedics is often quite a surprise, or not a surprise, but it's something we don't do a lot of, which is about the kind of the research and that side of things. And so that's a really good one. But I found that one quite tough going. So yeah, just have a little bit of summer and then start thinking about having a look at some stuff around that.
Yeah, the first module is different to the following 7, because we accept people who've got all sorts of different backgrounds and training and come through. And actually we have some of the certainly paramedics and a long time ago nurses wasn't professionalized and didn't have bachelor's degrees, so people can come onto the program through that without having a bachelor degree previously if they've been working for long enough in the field. So it's really important to get everybody up to scratch and thinking about how to work and study and how to think at a level 7 for MSCs. So that's really key. And if you can plan to be available on Thursdays, we always have tutorials on a Thursday, so try and make it easier to plan your rotas ahead. They're either at 11 or 1. They last an hour. They are recorded, but if you can be there and be present, then you can interact and you can get a lot more out of them, I think, than watching the recorded sessions afterwards. So we really hope to see as many people as there as possible. Thank you, Chris. Thank you, David, for organising it and being here today. Thank you to the students, and thank you to everybody for joining us, and have a lovely Thursday evening.